to welcome you to our first Vermont Oxford Network Ground Rounds offering. I've got Ravi Patel and Danielle Earhart joining me today. And what we're doing is we are rebroadcasting a session that Ravi and I did for the annual meeting that relates to necrotizing enterocolitis and transfusion practice. That'll take us almost about 35 minutes. But what we're really hoping is that we're going to open this to a broad discussion, some polling and some discussion, which Danielle will moderate, and hopefully Ravi and I can give some more answers. This is the first of an eclectic group of rounds that you'll hear about at the end, where we're trying to recognize that everyone is a little zoomed out at this point in time. And by our trying to coordinate and create a series that is predictable and scheduled well ahead, will help participants to interact more frequently. So I'll turn it over to Andy Warner and start the pre-recorded portion. Thank you. Good afternoon, and welcome to our session regarding transfusion practice. I'm Roger SOLL, and I'd like to begin the discussion with what do any of the new trials regarding transfusion thresholds tell us? As a matter of disclosure, I am the Vice President of Vermont Oxford Network and Coordinating Editor of Cochrane Neonatal, and some of the information that we'll be sharing will be coming from those organizations, and I have no other relevant financial issues to disclose. So let's spend the next few minutes discussing what evidence we have for the use of packed red blood cell transfusion guidelines. And first, of course, we need to understand the problem we think we're treating. There is a normal postnatal fall in hemoglobin concentration that is greatly accelerated in our very low birth weight infants. This anemia of prematurity is caused by a combination of suppressed postnatal response to erythropoietin and by rapid growth, and exacerbated by us with the iatrogenic frequent blood sampling. Oxygen consumption may be higher in our critically ill infants. When poor respiratory function reduces oxygen delivery, there may be at least a theoretical need for higher hemoglobin levels, so-called more boxcars to deliver oxygen to tissue. Oxygen unloading to the tissues is greatly affected by a variety of factors, including acid-base balance, carbon dioxide tension, and erythrocyte levels of 2,3 DPG. These effects are greatly amplified in adult rather than fetal hemoglobin, which is increased in the babies we transfuse with adult blood. When is a baby anemic? Who knows? Failure of an adequate oxygen delivery to the tissues due to low hemoglobin concentrations may be compensated by cardiac output, which is very limited in newborns, and by hemoglobin function itself. At some point, frankly, currently undefined, it is likely that growth and development will be impaired. The long-term effects of the very low birth weight having not had complications of anemia are not well documented. Measures other than hemoglobin levels have been advocated, such as oxygen availability, fraction of oxygen extraction, and the presence of clinical signs of anemia. But apart from the clinical signs, these measures are not easy to collect and have not improved the prediction of outcome. So we're stuck with using hemoglobin levels and hematocrit, which are frequently and easily available. Current recommendations advocate for maintaining relatively higher levels of hemoglobin in the early critical weeks, and clinical trials have reflected this practice by comparing hemoglobin levels based on gestational age and postnatal age. We do worry about infection. Transfusion-borne infections are rare but continue to emerge. The potential and unproven adverse events may be subtle and cumulative. Transfusions have been associated with retinopathy of prematurity, bronchopulmonary dysplasia, necrotizing enterocolitis, as you'll hear about later, and suppression of host resistance. Blood, which has been stored, contains pro-inflammatory microparticles, which may contribute to transfusion-related acute lung injury and organ failure or infection. There have been a variety of surveys regarding transfusion guidelines, here an international survey from 2012. This was predominantly done in centers in the United States, with 2/3 of the participating centers being US-based. And a little over half of those respondents said that they did not, at that time, have written policies with specific red blood cell guidelines. In addition, even at that time, they showed great variations in the recommended hemoglobin level at which a transfusion should occur. When we see if this is still a problem, we have Ravi Patel's survey about the variation in neonatal transfusion practice. And we know from that in fact, in the study that retrospectively looked at data from centers participating in the National Heart, Lung, and Blood Institute grant for donor evaluation, that in over 60,000 infants, there were a large proportion of neonatal transfusions that were administered at thresholds greater than supported by the best currently available evidence. So what is that best currently available evidence? Well, here we have the existing Cochrane review that frankly provides limited evidence on the issue of low versus high hemoglobin concentration thresholds. In the original review, there were 4 studies included, and these enrolled only 614 infants. The PINT trial by Carpellani and coworkers clearly enrolled the most infants, but that was only 451. In this meta-analysis, the only clear effect is a small reduction in the number of infants who are transfused once or more, with a 5% reduction in the risk of being transfused, which could be as much as a 9% reduction or frankly no reduction. No effects were really described on longer-term outcomes, including mortality, severe morbidity, retinopathy of prematurity, BPD, or brain injury. There was, however, a concerning suggestion that there might be an increase in necrotizing enterocolitis associated with the lower transfusion threshold. And although not statistically significant, the idea that there might be a 3-fold increase in NEC, I think, was disturbing to people regarding embracing the lower threshold. What were the authors' conclusions based on this review? They noted that the use of restrictive as compared to liberal hemoglobin transfusion thresholds in very low birth weight infants led to a modest reduction in exposure to transfusion and hemoglobin levels, and that there was no evidence of harms in using the lower hemoglobin concentrations. So, what's new? Well, there are 2 major new studies that have published on this issue. And let's discuss them each individually for a moment before we look at how they affect our collective decision-making. Again, we have Harish Kripalani to our rescue, doing a large trial of higher and lower hemoglobin transfusion thresholds in preterm infants. In this trial, Kripalani and coworkers performed an open multi-center trial in which infants with birth weight of 1,000 grams or less and a gestational age between 22 plus 0 and 28 plus 6 days were randomly assigned within 48 hours after delivery to either a more restrictive red cell transfusion protocol or a higher threshold. The primary outcome was meaningful to all of us: death or developmental impairment. This is just an example of the recommendations that were used in this trial regarding transfusion, and you can see that it depended in part on the respiratory support the infant was on, as well as the chronological weeks of age. In any case, this conforms very closely to previous trials' recommendations, as well as the trial we'll be discussing next. On average, infants had a birth weight of around 760 grams and a gestational age of around 26 weeks. There were no imbalances in the study populations. Regarding the primary outcome of death and developmental impairment, they were really quite similar in their results. The adjusted relative risk was 1, with a very tight confidence interval that suggests little benefit or harm. Looking at the 2 components, we can also see that there was no effect, hidden effect on death or developmental impairment. We, of course, are concerned about many of the secondary meaningful complications that have been related to transfusion practice. But in fact, there is no difference in the risk of BPD, retinopathy of prematurity, stage 3 or greater, grade 3 or 4 intraventricular hemorrhage, and importantly now, when they report on necrotizing enterocolitis, there is no difference, and it is a much more precise estimate of the fact that this does not seem to be affected by transfusion threshold. We also have the work from France and colleagues looking at the effects of liberal versus restricted transfusion thresholds, the ETTNO randomized clinical trial. In this trial, France and colleagues performed an RCT in 36 level 3 or 4 neonatal units in Europe among over 1,000 infants with birth weights 400 grams to 999 grams. They were enrolled at a slightly older age of 72 hours. The infants were randomly assigned to the more liberal or restrictive arms of the study, and the primary outcome was corrected death or disability at 24 months corrected age. Again, their criteria were very similar to the other criteria tested by trials, in which they varied based on the trial's criticality and the age of life. The birth weights on average were around 750 grams, gestational age is around 26 weeks, and again, no difference in the demographic populations. No difference was seen in death or developmental impairment. 44.4% versus 42.9%, an odds ratio that is narrow and confined around no effect. There was no meaningful difference in the components, death or cognitive deficit, and in particular cerebral palsy. Again, no differences were seen with some of the meaningful complications such as BPD, ROP, grade 3 or 4 IVH, cystic periventricular leukomalacia, or serious NEC. Here presented as absolute differences, but you could see that they were consistent with either minor risks or benefits associated with the transfusion threshold. So let's take a step back and do a little bit of a back of the envelope analysis, adding these two trials to the existing Cochrane review and seeing how it might affect our judgment. Well, the one effect that was previously shown was an effect on any transfusion in infants. And here we both have the risk ratio and the risk difference. And we see that there is still a decrease in the need for any transfusion associated with the lower transfusion, the more restrictive transfusion thresholds. This suggests an 8% difference in the need for transfusion that may be as much as a 14% difference or as little as a 2% difference. What we see when we look at the other meaningful outcome measures is that there isn't much of a difference between the two groups. The effect on death is not seen, with a typical risk ratio of 1.04 and a confidence interval of 0.87 to 1.24. We see no effect on necrotizing enterocolitis. We're now seeing a much more refined estimate that says that although the point estimate suggests a 17% increase in risk, it could be a 10% decrease in risk or a 50% decrease in risk, and a typical risk difference of only possibly 0.1 or 1% or minus 1% to 3%. No difference in neurodevelopmental outcome is seen when we look specifically at cognitive delay or cerebral palsy, and no difference is seen in any developmental impairment. So what can we conclude? Like previous studies, we are aware now that the more restrictive approach compared to the liberal approach for transfusion threshold leads to a reduction in transfusion exposure. When we look at that number needed to treat associated with the risk difference, we wind up with a number needed to benefit of 12. For every 12 infants we treat with a more restrictive approach, we'll have one fewer transfusion. This could be as few as 7 infants or as many as 50 infants, but it appears that a meaningful short-term benefit can be achieved. With these two studies, we can state with much greater precision that there is no evidence that using a lower hemoglobin transfusion threshold has any effect on mortality, major morbidity, and survival without major morbidity in very low birth weight infants. And so I ask you to consider whether or not it's time to at least either write or update your protocols regarding packed cell transfusions. We'll hear a little more about the risk of transfusion from Dr. Ravi Patel in the next session, and get together to discuss how this evidence might affect our decisions in our NICUs. Thank you.
Hi, everyone, and thank you to Dr. SOLL for the opportunity to present and touch on really the question of how concerned should we be about transfusion-associated NEC. You've heard Dr. SOLL present some of the data from the recent trials, and I'm going to share some of my thoughts of kind of where this leaves us about this issue of transfusion in NEC. I do have one disclosure. I do serve on the data monitoring committee of an ongoing trial of an investigational probiotic product. So, I framed this question to myself, and I've thought a lot about this. How concerned am I about transfusion-associated NEC today? And I did spend a fair amount of time thinking about this. On one hand, as a clinician, I'm less concerned than maybe I was a couple of years ago. I'm going to tell you why. Particularly when on a Monday I have to make a decision, an evidence-based decision about how I should transfuse infants. I think I'm in a much better spot today, partly because of some of the data that Dr. SOLL shared. On the other hand, I'm still a bit worried. And as a researcher, I think there are still some uncertainties, and I'm going to share why I still am a little bit worried. So let's go with why I'm less worried today than I might have been a couple of years ago. If we step back and think about NEC and the risk factors, I think it's important to consider this as a multifactorial disease. There's not just a single cause. This is a very simplistic, high-level view of what I consider some of the major drivers. The first and probably the most important is the non-human milk feeding that infants may receive. The best way to prevent NEC is the provision of mother's own milk, or if mother's own milk is unavailable, donor human milk. I think there's fairly consistent data on the role of that as a key strategy to prevent NEC. The second is inconsistent feeding, and that stems partly from data showing standardized feeding regimens or protocols have been associated with important reductions in the risk of NEC. The third is dysbiosis, and I think over the last decade or so, we've really had a better understanding of the bacteria that live in our preterm infants' intestines and colonize their guts and how that might be associated with disease. I think we've started to understand what some of those determinants might be, such as the use of prolonged exposure to antibiotics, potentially some of the human milk oligosaccharides that infants receive from mother's own milk. There's still some uncertainty about the role of dysbiosis, and particularly the bloom of gram-bacteria and what are the determinants of that, but we think that's important. But for today's talk, we're really going to focus on number 4 here, which is abnormal intestinal oxygenation. If you look at a lot of reviews on NEC, this is one of those areas that really hasn't been a focus. But I would say the best case for this, and what I think is the best experimental evidence that suggests this is important in the risk of NEC, is the data from the NeoPro meta-analysis. And I'm going to focus here on the outcome of NEC that stemmed from this meta-analysis of a number of different oxygen targeting trials conducted around the world that were pulled in an individual patient data meta-analysis. What you can see is that the infants that were targeted with a lower oxygen saturation target of 85 to 89% compared to those that were targeted with a higher target of 91 to 95%, those infants in the lower target had a higher risk of NEC, an absolute risk increase of about 2%. That was a significant, statistically significant increase, and I think a clinically meaningful increase as well. And this is probably the best experimental data that suggests oxygenation in an infant influences the risk of NEC. And here we're looking at oxygenation. So if you take this from a physiologic standpoint, what might be going on here? And arterial oxygen saturation targeting is probably one of the important determinants of how much oxygen our infants, preterm infants, have in their blood. When we consider that alongside with cardiac output, that is going to influence how much oxygen is being delivered to tissues, the brain, the gut. And that, along with consumption, might be an important determinant of the sufficiency of oxygen delivery. Now, this is a very simplistic view. There are complexities, for example, the affinity of hemoglobin to oxygen and other factors that play a role. But if you think of these determinants, on the right, the saturation determinant is really the targets we aim to achieve for infants and some of the data I just shared. But on the left, the hemoglobin, this is really determined by the approaches we take in terms of the tolerance of anemia and the transfusion practices, which is the major way in which we influence hemoglobin, the other being the use of delayed cord clamping and some of the practices regarding the frequency of phlebotomy. So let's focus a little bit on this. And there's been some interest in associations between both transfusion and NEC and also with anemia and NEC. And one of the things we did 5 years ago was try to unpack these associations. Importantly, because transfusion is often given in response to anemia. And when we look at the associations that have been reported in the literature, the question was, is it the transfusion? Is it the anemia? As I'll show later, maybe it's both. But in this study, specifically when we looked at whether there was an association between red cell transfusion a given week, using kind of approach accounting for repeated exposures, we found no relationship between red cell transfusion and the risk of NEC. By contrast, when we looked at severe anemia in a given week, using a threshold of less than or equal to 8 grams per deciliter, which was at the time informed by the lower thresholds in the trials, we did see a significant association with a rather imprecise estimation, one that was statistically significant. This was observational data, so there's always the risk of confounding, and I think that's an important limitation of this data, even though we did attempt different ways and different models to try to account for confounding, including the use of propensity scoring to address confounding by indication. But observational data always has limitations with causal inference in my mind. And so I've really been waiting for the results, long awaited, for 2 important trials to inform how we transfuse extremely preterm infants, the TOP and ET2 trial. And those build upon the findings of 2 prior trials, the Iowa and Pint trial. And you heard from Dr. Roger SOLL about these trials, which I think provide good evidence, the best we have, about how we should transfuse infants. And I do believe, for the most part, are generalizable to most of the infants we care for in the NICU that are extremely preterm within the gestational ages studied. Now, if you look specifically at what these trials showed with NEC, which was a secondary outcome, not the primary outcome, you can see here that there's no significant differences in the incidence of these outcomes with risk estimates that were close to the null, although some wide enough confidence intervals that it does include estimates that could be compatible with either benefit or harm. But I think for the most part, these data suggest there's not a clear effect of one threshold versus the other on the incidence of NEC. And I think these data, along with some of the other primary outcome data for these trials, are going to be the most useful evidence we have to guide where our practices are today. Now, how do these data align with what clinicians are already doing? This is what we pulled and recently published from the National Heart, Lung, Blood Institute REDS 3 study that was a cohort of about 60,000 infants from 7 US centers. And this allowed a measure of the hemoglobins that were actually used or associated with red cell transfusion within 24 hours prior to red cell transfusion, to get an idea of what were the thresholds that clinicians were using for transfusion. And when you look at this, it's a very classic bell-shaped curve and distribution. You don't see this bimodal distribution, which, 2 humps that suggest that there was groups of clinicians that used lower versus higher thresholds. Really, there was this kind of distribution where most infants were being transfused at this kind of peak here. And when you overlay the thresholds in the TOP trial, the ranges of thresholds, which differed based on postnatal age, on level of respiratory support. But in general, you can see that this kind of captures the higher, more liberal thresholds in that trial and the lower, more restrictive thresholds. And so the thresholds studied in that trial, I think, reflect, at least in this cohort of 7 centers, what is current practice. And probably most clinicians at the time this trial was ongoing were somewhere in between these low and high thresholds. And I'd like to contrast that with severe anemia, or looking at really those infants that hemoglobin's less than or equal to grams per deciliter, where really this is this tail end of the distribution of what thresholds are being used for transfusion. So what do we make from this data, and why I'm less concerned today than I was a year or 2 ago, is that these recent 2 trials show no better or worse outcomes with the use of high versus low thresholds, including the secondary outcome of necrotizing enterocolitis. And for most clinical situations, I think this would favor more restrictive or lower hemoglobin transfusion thresholds if there's not a clear benefit of using a higher threshold. Now, I would like to make the point, and I know this is a point that's been made by Dr. Ed Bell and others, is to be careful about using thresholds lower than studied in practice. That these were thresholds that, even in the conservative arm for certain infants, was a hemoglobin of 11 grams per deciliter. as low as 7 grams per deciliter in some infants on room air after 3 weeks of life, but really to be careful about being more conservative than that was studied, because I think there's uncertain safety of those thresholds. Now, transitioning now about why I still am a bit worried, and thinking of why I'm a bit worried. And this is really from my thoughts as a researcher in terms of what are some of the uncertainties about this association. The first is what we know from mechanistically what anemia might do to the intestines. And this is work from Connie Arthur and Sean Stoll, who were previously at our institution, are now in Boston. And the work they did looking at it in a mirroring pup model, making these pups either anemic, here down to a hemoglobin of 8 grams per deciliter, or controls that were just pricked but not bled, and comparing what the effect of anemia was on the intestines. And what this study showed was that those pups that were made anemic, they indeed had hypoxia in their villus, in their intestines. And that could be measured by a stain called hydroxyprobe, that you indeed saw that the effect of anemia in these pups who looked otherwise well, they indeed did show evidence of tissue hypoxia in the gut. And that hypoxia led to activation of HIF-1 alpha and activated macrophages that were resident in the intestinal tissue. And these activated macrophages produced interferon gamma, which is a pro-inflammatory cytokine that was thought to associate with disruptions in the tight junction barrier, making the intestines more leaky, potentially placing these intestines at risk for where bacteria that were in the lumen could get into the basolateral aspects of these enterocytes and potentially cause inflammation, which is what we know is one of the important determinants of NEC. So this is very early work, but I think suggests there is this impact of anemia on intestinal injury. And building on these findings are work from the lab of Akhil Maheshwari, where they looked not only at anemia, but the severity and duration of anemia. Here again, in mouse pups over the first 20 postnatal days of the life, if we look at P14, that's about 14 days, is similar to the intestines of a 24-week gestation preterm infant. And on the y-axis is how permeable or leaky these guts were. What we can see is there's a clear effect of severity. The more severe the anemia was, the more leaky the gut was. There was also a suggestion that there was a developmental susceptibility, that this went up over time and was greatest at 14 days, and really that over 2 weeks, the effect of anemia might be increased. And I think this has clinical relevance in terms of not only considering anemia, but also the severity and duration may matter, and also potentially that developmental susceptibility to this. Now, what happened when you added transfusion? This is also from the same group in a different publication, looking at actually the interaction between anemia and red cell transfusion. And I think this is really very important mechanistic work, again, only in a preclinical model, looking at the effect on a biomarker of gut injury, where it was really this last group of mouse pups that were not only transfused, but were anemic and transfused. And that both of these factors, that anemia was necessary for gut injury elicited by transfusion. Whereas if these pups were just anemic or just transfused, there was no injury. And I think these data suggest, at least mechanistically, it might be a combination of these two. Now, one of the limitations, I think, to acknowledge is really when we're looking at hemoglobin, we're using this, and it's been used over a century and measured for over a century as a biomarker of, if you think back to the equation I shared, of the sufficiency of intestinal oxygenation. But how good of a biomarker is it? This is very recent data. We have just finished from a cohort. We finished enrolling 220 infants as part of a study, and this is one of the major aims, was to try to understand how anemia relates to tissue oxygenation. This was achieved in 74 infants with a mean gestational age of 27 weeks, where we took each measure of hemoglobin and paired it with a measure using near-infrared spectroscopy of regional tissue oxygenation. What you can see is that there's really this very weak correlation between the degree of anemia and the mesenteric tissue oxygenation. Although it's statistically significant, I would suggest it's a very weak correlation. It suggests that anemia may not be a great marker of at least the regional tissue oxygenation in a preterm infant. The other aspect that's been a lot of interest is what about feeding during transfusion, and there are ongoing trials, the WHEAT trial that's ongoing in Australia and maybe starting up in the UK, that are looking at this question. But if we look more simplistically at, is there a change in the mesenteric oxygenation measured from years from before to after transfusion, comparing those infants that are feeding versus not feeding, there's no significant difference in the change in oxygenation following transfusion. Typically, you see some increase, about around 10% in the mesenteric oxygenation, with a lot of variability, but no difference between those infants that were feeding versus not. And finally, I wanted to touch on when we transfused, but what we transfused. There's been a lot of focus on the when, the what, the hemoglobin threshold at which we transfuse, but less of a focus on actually what we're transfusing into the preterm infants and what's in the red cell bag that's being given to infants. I think there's a lot of opportunity to try to understand among centers in the US, what are actually the characteristics and practices in the blood bank of what's being used for transfusion. But one aspect that I wanted to highlight, and this is relatively recent work we've looked at, is actually some of the characteristics of the donors of the blood that's being used for transfusion. And in this study, what we did is we looked at very low birth weight infants who received red cell transfusion from only females or from only male donors, and looked at the incidence of recipient outcomes in these two groups, adjusting for transfusion intensity and birth weight, the major confounders. And what we found was that those infants who received blood from only females had a lower incidence of adverse outcomes compared to those infants that received transfusions from only males. You can see the incidence there, the odds ratio, which was statistically significant. If you look at NEC, among those infants that received transfusion from female donors, 1 of 56, or about 1.8%, developed NEC compared to 12 out of 125, or 9.6%. So I think although these findings need to be validated, that this suggests it's not just when we transfuse, but potentially the importance of what we transfuse. And this is one of several factors of the characteristics of red cells that are being transfused in preterm infants. And I think a lot more opportunity to try to better understand how this may or may not influence recipient outcomes. So as a summary of some of the uncertainties, I think we're trying to unpack what are the mechanisms that might explain some of the effects of severe anemia on gut inflammation injury, which we've seen in mice, and are these relevant to preterm infants? And I think this is still an area of uncertainty. And as well, we've kind of taken for granted, and today we use hemoglobin for guiding transfusion or hematocrit for some centers. That's likely going to be the case next year and the year after. But how good of a biomarker is this really for what we're hoping to measure, which is the sufficiency of oxygen delivery to various tissues? And do we have better alternatives? And finally, some of the characteristics of the blood being transfused. And do transfusions from older female donors reduce the risk of adverse outcomes compared to transfusion from younger male donors? Because what I didn't mention in the prior slide is there's also some association between the age of donors. So with that, I wanted to acknowledge a number of our colleagues, in particular Cassandra Josephson at Emory, support by the NIH, and really to recognize some of these uncertainties. What are we using to transfuse preterm infants? I think there's opportunities to survey those practices. And I'm really delighted that the Vermont Oxford Network has decided to partner with the NHLBI-supported REDS4P program, which is a multi-year program to better understand transfusion practices and association outcomes, including what we transfuse in preterm infants. And that has just started, supported by the National Heart Lung Blood Institute and the NICHD. So I wanted to thank again the Vaughn for the opportunity to present, and would love to hear questions from the audience, including some of how some of these trials are influencing your practice.
Well, fantastic. It's fun to hear that again, Ravi. We're now in our live version. You've got Ravi, Danielle, and myself here to discuss and answer your questions. I don't think we have any important disclosures. They're listed here, but really no relevant financial issues to disclose. We're going to start with some polling, and I'm thrilled to see well over 500 of you joining us at this seminar, and I'd like all 500 of you to be working the polling questions. So first of all, chat anytime. Many of you have already, and Danielle has been moderating that, and we'll fit some of that in the polling section, but definitely get to it in the 10 minutes or so we're going to leave at the end. For polling, we would love to have you use Poll Everywhere. Here are some of the instructions around how you can do it, and I'll leave this up for a second. You can open your web browser and type in pollev.com/VT-Oxford. You could download the Poll Everywhere app and select the joint presentation and type in VT Oxford, or you can simply text VT Oxford to 22333. And let's just take a second to look at you guys to work on your polling figures here. I couldn't help but add that last one because we are also zoomed out, and I see that 1 or 2 out of 100 of us thinks the way I do on this. But I'm also thrilled to see so many people joining us for the first time. It looks like it's around 1 out of 3. So welcome, and I really invite your active participation, and I'm happy to see you here. So let's start with a straightforward issue. This whole issue was framed around what are the risk factors for NEC? And is it feeding non-human milk? Is it inconsistent feeding? Is it dysbiosis? Is it abnormal intestinal oxygenation? One, I'm forgetting who chatted it in, but also just prematurity isn't listed on this, but clearly that's part of it. And so let me just move on to Ravi's slide that looks at these. The answer, of course, is all of it. We're focused when we talk about transfusion, some of these practices, on this issue down here of abnormal intestinal oxygenation. But clearly there's a lot to it, and as we discuss things, we may get to some points that are further afield than just this issue of transfusion and NEC. Let me ask you a question that relates directly to that issue of oxygenation and oxygen targets. We've been talking a lot in the neonatal community about lower saturation targets, but what are the risks and benefits there? So it looks like about 70% of you think that there is a benefit from lower targets, but there's still a fair number that doesn't pop up in your mind. And so let me just turn it back over to Ravi, who made this point in his talk about the impact of some simple practices around oxygenation and outcome.
Thanks, Roger. It's great to be back here with you, and thank you, Devon. I think when we see classic descriptions of risk factors for NEC, oxygenation is not at the top of people's mind. And even when we think about oxygen targeting, as you pointed out, we're thinking of retinopathy of prematurity and mortality. And I think what I found very important in this NeoProm meta-analysis, which was a combination of many pulse-ox targeting trials across the world, is this effect of oxygen targeting on NEC. And I think this, from an experimental data, probably provides, to me, the most compelling clinical evidence that it probably does matter. Oxygenation does matter on the risk of NEC, and that those infants with lower saturation targets have a higher risk of NEC. I think we still don't really understand why, what the exact mechanisms are, but from a clinical standpoint, I think this is relevant. And based on these and the trials that underlie this, I think many of the centers have switched to higher saturation targets, largely because of the effect on mortality. But I think this is also a secondary benefit, might be an influence on NEC.
I was really glad when you brought that up, because I tend to always frame that question as the trade-off between death and ROP. And in fact, someone's thumb is on that scale, and that person is NEC, saying, no, actually, it's a more complicated decision, and it probably more strongly favors going with the higher threshold.
And I think the other point is on the other direction is BPD, which is also something that we don't see commonly in that equation, and just how important saturation targeting is for all those outcomes that we care about in preterm infants, that it really is one of those interventions that has a large impact on many different neonatal outcomes.
Yeah, so I'm glad I advanced this slide a little early, Ravi, but I'm glad because it's got a lot of activity. And I'll be honest with you, I don't know I would answer it. We've got a huge variation with, a little over half saying no, not an association, but the other half of us going, either I don't think so or no. So what do we have to say on that? I guess I'll start it off, Ravi. One thing is that before we had the recent trials on transfusion threshold, there was a tiny signal that went the opposite way, that in fact, the more liberal criteria for transfusion were associated with less NEC, and that juxtaposes to so many of the other publications. But with the additional data, it's not that we have that precise an estimate, but we have a much less worrisome concern that we're going to negatively impact on NEC. But your models are complex, and I know you just went over them in the recorded talk, but I thought it was worth some comment about, how much certainty do you have based on this?
I would agree that these trials have provided probably the best available evidence of the effect of NEC, with the caveat that they are specific to the thresholds studied in those trials and that the clinicians adhere to those thresholds. This was a study we did that was an observational study that I think tries to untangle is it the transfusion or is it the anemia that leads to the transfusion that might influence the risk of NEC, because they're both related. And looking here at a threshold that probably is lower than what was on the conservative arm of the trials, because this was an absolute threshold regardless of how old the infant was at any given age, that suggested that it really wasn't the transfusion that was associated with the risk of NEC, but it was really this potential that how anemic they were in the kind of week before they developed NEC was a risk factor. And I think this pairs with the preclinical models that suggest there is a mechanism for why this might be, and maybe it has to do with tissue hypoxia and the inflammation that results in. And I think this is important to put in the context of hemoglobin levels that might potentially be even lower than those that were from the trials for some of these infants. And I think that this is observational data that comes with limitations. So when you're at the end of the day, you should really focus back on the important information that's provided in these recent trials, the top trial and the ETTNO trial, and that really should be what's guiding practice.
We had an interesting chat that had come in about some pressure people were feeling in the midst of a blood shortage. And, we all do this with evidence. We say, okay, well, here's what was shown in the trial, but then we make it sort of generic. So lower is okay, as opposed to what the tested limit was. So one of the questions was, what do you think if you applied adult type criteria, which, I'm guessing, knowing from myself and other adults, that's around what, a hemoglobin of 7? Comments on extrapolating the data and the dangers, it sounds like you're saying, of that?
I've received those emails. I think there's really a concern about blood shortages today, but I would say there should be caution with going lower because of these concerns about the effects that anemia and oxygenation might have on the gut, and that the safety of thresholds lower than those in the trial have not been studied. And as much as we want to be good stewards of the blood patient blood management and what we're transfusing, I think we really should be cautious about suggesting that because these lower thresholds in the trials didn't show increased harm, we can go even lower than that. I think we really need to kind of adhere to the more conservative approaches in the trials and not lower.
I certainly agree, and that's important. I mean, that did come up as one of the questions, and important to understand that we're not talking about pushing things lower. We're talking about what the trials have showed us. Towards that end, the new trials point in the same direction as the old trials, but they do add some precision to the estimates. And I think that they push us towards really contemplating what unit policies have we set up. So just looking here, again, it looks like most everyone who's tuned in today, 70% plus do have it, but there seems to be an important, 1 out of 4, 1 out of, 5 that don't have that. So I know that you've looked, and you in your recorded section discussed a little bit about variation in practice. So let me turn it back over to you, Ravi, to talk about what you see in terms of variation. What is healthy variation? What is unhealthy variation? So let me turn it back to you.
I think it's a great opportunity. These trials should be a nice way to stimulate discussion in your groups for those 25% of you that don't have guidelines. I think that's the best approach to translating the evidence from these trials into actually in your practice. And you know, when you look, I think when you're designing a trial, you're generally trying to get at the kind of extremes of what people practice in their practice. And so these high thresholds were, you know, kind of on the upper end of what people would typically practice, and the low thresholds on the lower end. In reality, at least in this data set, most clinicians were somewhere in between these two thresholds. But I do think that the trials, if there's not a benefit for giving more transfusions or being more liberal, then I think they do support this lower range, depending on how old the infant is and their illness severity. But to be cautious about this tail, and what we're really talking about with kind of the concerns with severe anemia might be really these infants at this very tail end of pre-transfusion hemoglobin. And I think that's important to consider. And guidelines can help because they ensure, instead of a clinician thinking about a number, which might not be applicable given how old the infant is or how sick they are, I think having something on a guideline on paper is a good way to ensure that you're following the approaches in the various trials.
Great. Now, I have to say, our participants have not done what I was worried would happen. When you get Ravi on the program and you're talking neck, I thought there would be about 1,000 questions about probiotics. And before I sidetracked the entire discussion, I thought that we should at least take a second to talk about probiotics, which is not about oxygenation or transfusion or anything, but just tuck that one away. And maybe a little bit of a discussion. Let's get Ravi to sort of give us his current thinking, and then we're going to open things up to a more general discussion. So just in terms of what you think the evidence shows about probiotics.
I think that the number of trials and the precision of estimate of effect is likely not going to change, even if there's more studies. And I think the uncertainties are really about which product you use. And that probably is what's limiting clinicians about the uncertainties of kind of the optimal product. I think there's still a fair number of centers that use it, some that don't, and those are very individual decisions for NICUs to make based on their risks and what else they've done to reduce NEC.
Yeah, no, 53 trials, and I'm still uncertain, Ravi. And it probably relates to this whole issue of how this type of product gets manufactured and used, and the fact that I wouldn't know what product to choose, but I can't help but think that there's something important going on here. In terms of your question about how many people have embraced this, looking at VLBWs, we see a rate of around 16, 17%. And I'm assuming that's not picking and choosing your VLBW babies. That's assuming that, 1 out of 6 centers has adopted this as a policy. So it's still interesting and not fully disseminated, but we can tuck that away from our general discussion, which I would love to move to now. So Danielle, I'm going to hand over to you and see what we got in the chat or other questions that have come. Let's have an open discussion.
Sounds great. And we have quite a lot of excellent comments, questions, dialogue going on in the chat. So I will try to get to some of the top ones, but please keep sending them in and we'll take note of all the ones that we don't get to in the chat. I thought one that we might just start off with, Ravi, is coming back to a point that you made in your presentation. And really you highlighted that anemia is just not a great marker of tissue oxygenation and tissue or oxygen delivery. And so thinking of, all of the different factors, of the infants, are they the sick term infant? Are they the ELBW infant? How old are they? What's the reason they have anemia? Just maybe your thoughts on, should we be thinking about that from a, more fine grain approach, or do you see things on the horizon that will help us kind of take those tables and tailor our approach to the patient at the bedside in front of us a little bit better? And maybe Roger, you have some thoughts on that as well.
I think that's a great question. I think in the near term, hemoglobin is still going to be, or hematocrit is still going to be what clinicians use. Those are what the trials informed, and they come with limitations. The hope is that And I would say the evidence is still not clear yet on the use of tools such as near-infrared spectroscopy that might better measure kind of the regional tissue saturation. I think we still don't know the exact threshold above which we want to keep that number. And trials like the one that's currently being done, the SafeBoost 3 trial that's being led at Copenhagen, I think that's going to be the largest study that really hopefully gives us an idea of targeting that, using kind of regional oxygen saturation as a target, with the caveat that there's lots of things that can influence that. It's not just your hemoglobin, it could be your blood pressure, your cardiac output, your oxygen saturation. And so it does make it tricky because you're having multiple different interventions that each carry risks and benefits that can be used to modulate that number. But I think that would be the most promising tool, but not yet ready for, I think, routine clinical use.
Yeah, and I would argue that that's the least of its applications, frankly, that almost everything about our management, when we think about it, it's how does it affect the brain? And when to transfuse will be one of multiple choices to make about how we assess what is the right perfusion. You think of this as a little bit like our oxygen saturation monitors on steroids. I mean, there's just so much more to follow and to think about, but it might help us understand better about who will benefit from transfusion. It's hard to think of it as simple a marker as hemoglobin and hematocrit.
And what I didn't show, but in work we've done, it's really those babies that have the lowest regional tissue oxygenation, at least in the mesentery, that are the ones that tend to have the better response. And that similarly has been shown by other groups. Whereas if you start with a high level, you're likely to end with that same level at the end of your transfusion. You're probably not getting what you're hoping to achieve with the red cell transfusion. So I do think that there is some benefit to those therapies, those tools, to understand what effect is actually a red cell transfusion having in your patient.
I think there was a question in the chat that sort of asked about the fact that is it a combination of the poor mesenteric flow from anemia and the transfusion on top of it, not saying the transfusion caused it. Is that part of your thinking, Ravi?
I think that's that's suggested in the preclinical models that it's a combination. I do think that there's effects of anemia that might be priming the gut for kind of an inflammation, and that there's another insult, and that might be a red cell transfusion. There's studies that have shown red cell transfusions are pro-inflammatory in preterm infants, and maybe that's one of several potential inflammatory stimuli that kind of elicit injury. Although I think the mechanisms of that are still not fully worked out. It might actually have to do with not just the red cell transfusion, but actually the characteristics of that red cell transfusion, and potentially the quality of the blood being transfused in terms of the impact it might have with both of those things together. So I do think that there's a possibility of interaction, although it's something that hasn't really been well studied in babies.
There's another interesting question in the chat, Ravi, now that you're talking about kind of what else is in those transfusions, and some interesting questions about the work that you've looked at, the sex of the donor, but then also the content of the transfusion that is not the red blood cells. And so a few of our members today were just curious if you had insights into, is there research really focused on that other 50% of the transfusion, things that we should be kind of
Recording in progress.
That are still left in there that might have pro-inflammatory effects. There are things, for example, like free heme that might be in these units that elicit. The caveat being, in adults, the trials of older blood really haven't borne out and shown that it's actually harmful, that there's not any evidence of benefit of giving fresher blood, including one trial that involved preterm infants. So I think that although there's been a lot of worry, how old the blood is hasn't really shown to be an effect. Now that the donor characteristics is something we're really interested in. And we do know that female donors have a lower hemoglobin. and actually that the viscosity of the blood also differs based on that, probably partly driven by the lower hemoglobin female donors and also by other factors, and that might actually influence how that blood flows into the neonate. And I think that's an area where we're very interested in kind of exploring further.
That's great. A lot to look forward to. And I think we have maybe time for maybe 1 or 2 questions left. And Roger, when you thought of Rob, you thought we were going to get so many questions on probiotics. I was thinking we were going to get so many questions on, do you hold feeds during transfusion? So of course I have to get back around to that. There are quite a few questions around, you know, what to do when you're transfusing. So you have a guideline, you've met it, you're going to transfuse this baby. What are some other things, you know, that are evidence-based that we can do to think about, you know, the care of this baby? So the big question of, you know, withholding feeds. If you do it, how long is that? How long should you do it for? How much should you transfuse? But I think really the concept of withholding feeds during transfusion, I think a lot of people are interested to hear what you have to say on that.
That's an interesting question. I think a very relevant topic. Some of the largest kind of planned trials in our field are actually ongoing right now to address that question of holding feeds or not. The challenge is the absolute risk of NEC within 48 hours after transfusion is really low. It's about 0.5%. So if you're holding feeds, you might remember the one baby that got NEC after a transfusion, but there's going to be a lot of babies that actually didn't develop NEC. And what's your tolerance of that practice of holding feeds, maybe putting in an extra IV, you know, stopping feeds, and if the baby's getting lots of transfusions, how long that's going to delay reaching full feeds? I think there's some unintended consequences, and I am not yet convinced of the data. The meta-analysis that's been on this has been largely observational studies that have been kind of pre-post approaches that also change not just holding feeds, but also increased use of breast milk feeding or other things that kind of make it unclear about how much of an effect actually withholding feeds has on transfusion. So not something that I routinely practice. I think there's a fair amount of uncertainty that these trials are hopefully going to give us some better information to guide what we should do.
Great. And I see Cami Martin chiming in the chat, who is one of my mentors as a fellow, also agreeing, saying that there really is no current evidence to support holding feeds. Any thoughts to chime in on that, Roger?
No evidence is no evidence.
Yeah.
Debating what the theoretical risks and benefits are, as Ravi said, what are the downsides to the dozens and dozens of infants you'll do this to prevent that one theoretical case. Be good to, I'm glad that trials will hope to address this.
Perfect. And with that, I think we have reached the end of our discussion period. It flew by. So I just wanted to thank everyone for their great comments and questions in the chat. We'll take a look at those that we didn't get time for. And I'm going to pass it over to our Director of Quality Improvement and Education to close up the session today.